and welcome everybody to Season 8, Session 1 of Maternity and Midwifery Hour, and welcome back from the little break we've had. My name's Sue Macdonald, and I'm the curator of the Maternity and Midwifery Hour and the Maternity and Midwifery Festival. And forgive me if my words go about a bit wobbly this evening, because we had the festival yesterday, very exciting, but it leaves you a little bit, where am I? I'm in the maternity hour, so it's great. And so I'm really so delighted this evening to be joined by my colleague, Dr. Denise Tehran, who you'll see by the side of me there, and virtually by Tamsin Bicknell, because Tamsin can't be with us, but she has done a really lovely presentation that we're going to have as part of this. But we still, as we always do, put our guests on the spot and ask them to share a moment of the week. So I'm going to ask, first of all, Denise, I think, to share her moment.
Well, my moment of the week, I think in light of the death of the Queen, it has brought back to me the time that I met the Prince of Wales as he was at the time. I was very fortunate and honoured to be awarded an award at St James's Palace for my work with complementary therapists. But he did then come to see me and to chat individually. And we had a very exciting conversation about his butler's constipation.
Oh. No names, no pack.
No. Very exciting.
I have to say, Denise, that is one of the most interesting moments of the week we've had, I think. It conjures up all sorts of interesting images, I must say. Now, I know Tamsin did a little moment of the week, and I think Amy, who is our behind the screen supremo, will probably share it for us. Is that right, Amy?
So my moment of the week was yesterday evening. I've been doing a lot of recruitment recently for some really exciting roles, and I've been really excited by the candidates that I've had coming through and the people that I've recruited. So yesterday I did some interviews, and I was able to tell the person who was successful, and the amount of screaming that she did down the phone, we were both in fits of laughter, and it was a really exciting moment to think that this was related to a new service that's going to be created, and to hear somebody so happy about an opportunity and to feel so excited about working with someone in the future was a really nice moment to have, particularly as I'm now on leave for a week. So it was a nice end to my working week before my holiday.
And what a lovely moment to share also. So we had two really good moments to share. Okay, well, I'm going to go and do the usual sort of welcome. We're not losing Denise, and we're not losing Tamsin, but I'm just reminding people where we came from, the Maternity and Midwifery Hour was born during the pandemic as a way of making sure that midwives, student midwives, aspiring student midwives, I know we have some paediatricians and doctors who come in as well, just to get some up-to-date information. We did quite a lot on COVID at that time, and link up and feel as though linked up. It sort of reminds me a bit of what happened and where refresher courses came for midwives in the 30s and 40s as a way of breaking that sort of geographical distance. And we've kind of carried on. So we're in our third year. We're supported by Matflix, who look after everything, make sure everything's recorded, and then we have a huge, I think it's over 1,000 videos kept. So you can access any of these videos. You just have to go to the Matflix website and have a look and choose anything. And it's really good resource for those of you doing any study work. If you're doing your revalidation, for those midwives there who might be thinking about it, loads of information, and it's very accessible and really interesting. So you get lots of up-to-date things. And there's also our lovely Dr. Jenny Hall does a wonderful kind of service in putting them in box sets, in themed sets. So that can be really good. And that's available at a small subscription, but it's well worth trying that out. And we're very happy for people to share. In fact, we like the idea of people sharing all the information and any clips or any of the presentations people have seen with their colleagues. Some people have little watch parties, and that can be great fun, because that means you can have a kind of discussion and expand it out a little bit more. And of course, if any of you out there are thinking, well, I could be on that, I'd like to come on the Maternity Hour, just get in touch and we might be able to organise something, because we're always looking for interesting people and presentations. And I should add there, well, all midwives are interesting and all students are interesting anyway, but yeah, put yourself forward, that'd be great. Now we're coming to the end of the autumn. I can hardly believe I'm saying that. The days are getting a bit shorter. And we're coping with not just the after effects of COVID, but we're also with this rising cost of living and the fuel crisis and everything. And of course, the recent loss of Queen Elizabeth II last week. And that's a huge occasion. And it is a time for many of us for mourning and remembrance for all of us. And I want to just say a few words, because I usually do a news slot at this point. And of course, most of the news now has been overshadowed by the news of the Queen's death last week. I mean, she died at the age of 96, quietly and very peacefully at home in Balmoral. And she'd been working up to 2 days before, which was very typical of the woman she was. But it's interesting, because I think I, like many people, imagined she'd be there forever, because she's always been there forever, ever since I was a child before. And she'd been a queen for 70 years, and she'd celebrated a platinum jubilee this year. And that was such a joyous and uplifting occasion, with very much ceremony. And also the Queen showing a wonderful sense of humour. And I'll never forget, I'm sure a lot of you will never forget, that wonderful clip of the Queen taking tea with Paddington. And then with that irrepressible twinkle in her eye, finally revealing what she has in her handbag, which was a marmalade sandwich. I'm not sure, but it was a lovely, lovely clip. And I think the images, I'd just like to share just something now, which I meant to do. A bit slow for that, sorry. It's a bit slow to work, sorry. Okay. Oh, but the next one isn't. That's the Queen. We have the Queen on. Oh, there. This is, I mean, this is a lovely image, and I think the dear me, I'm flipping around. Sorry. So I wanted to get it very perfect, and it always skips a little bit. But I wanted to sort of really highlight the fact that the Queen was very much a woman of her time, but she was also well ahead of it. And I think the examples included her training to be a mechanic and working on and driving around great big lorries during the war. And of course, she had all her 4 babies at home, attended by a midwife. I mean, there was an obstetrician there, obviously, as you would expect. And in fact, she was a real path trailblazer at that point, because for her last baby, she had at home with Prince Philip present with her during the birth, which was very unusual. And this was 1964. And this was really trailblazing. She really kept up to the minute. And I'm thinking also, more recently, she kept up to date with her Zoom meetings, and she was really good on Zoom as a way of communicating with people. But I have to say, it's very sad, because it's a time for mourning for the nation. It's a time for reflection, but it's a time to remember a life very well lived, and really celebrate the continuity and the strength that Her Majesty gave us. But I think it is also important to remember that when we lose somebody of this sort, we're reminded of our own mortality, and more importantly, of the precious people we have lost. So it's a painful time for us all, I think. But as the Queen herself said, grief is the price we pay for love. And I know this has been repeated a lot, but it's very meaningful, I think, and very right. So may she rest in perfect peace. And of course, God save the King. And there's a lot happening at the moment. And I'm just going to now stop sharing and come back. And just to lighten the mood a little bit as we come back, we're going to be looking this evening at professional and personal challenges. And first of all, I'd like to introduce Tamsin Bicknell, who's a consultant midwife for public health and safeguarding at Homerton University Hospital. She's also visiting lecturer at City University, has a strong social justice focus, and enthusiastic about knowledge sharing, developing, supporting staff, and collaboration across traditional boundaries, which we all need to be very aware of these days. She's also a co-chair for the North East London local maternity and neonatal system. She has huge experience in public health. And I asked her to talk about midwives managing hardship from a perspective as a midwife, because we hear that nurses and midwives are having to go and rely on food banks in some places. And that can be very difficult. I have to think that you're relying on charity where you've always been very independent, but also from the perspective of helping women and families and identifying women and families who might need support as well at this time. So we're going to move on to Tamsin. If you have any questions, I think the best thing to do is send them into the chat box, and we'll send them on to Tamsin for when a nice little return when she returns from her leave. She'll have a little bit of work to do to feed back, and we can feed that back to people. So I think my colleague, again, Amy, will now start the clip.
Thanks, Sue. My name's Tamsin Bicknell. As you said, I'm a consultant midwife in North East London. And I'm just going to talk a little bit about the cost of living crisis. I've called this a bit of a toolbox for midwives. I'm keeping it quite simple, but what it is a way of making sure that you've got things in a kind of virtual toolbox in your mind to help colleagues, help yourself, and help the families that you work with at this difficult time. So yeah, I divided it into two parts. And I think just to start off by saying that I think we're all becoming increasingly aware of the public health role that midwives play, and the huge amount of access into the details of people's lives that we're given, and the opportunity that we have to help them make the most of any support that's available, help them understand what's out there, how they can access it, and also look after our colleagues as well, because we know that this is not a crisis that's isolated to people who are very, very low income. It's actually reaching up and affecting most people. So this first slide is around for yourself and for your colleagues, because, you know, I'm a firm believer that actually in terms of helping professionals, we need to make sure that we're okay before we have the capacity to really do our best for our colleagues, for our patients and our families that we work with. The first thing I've put on here is organise. Are you in a union? I think at the moment we're going through the discussions around the pay award or the pay cut in real terms, as it can be seen. And I think that the beauty of being in a union is that you are part of something bigger, and you are part of something that can enact positive change. As well as responding to the ballots, getting involved, being an activist in whatever way you can, there is power in those numbers. Like, we are the union, and actually if we don't step up and speak for each other and speak for ourselves, then those things won't change. Unions also have things like hardship funds. Lots of us might be in the RCM. They've teamed up with the Cavell Trust for nurses. They have a benevolent fund, so you can apply for anything really that you need. It might be something really small, like your cooker stopped working, or it might be something a bit bigger, but there's access to that and information on the RCM website, or whichever union you're in. I'm sure they all have them. In terms of employers and your local councils, I think this is something that is varying quite a lot across the country. There's been some really good examples of trusts who've planned things like school uniform swaps, hot meals for children of families that work for them, hardship grants. I think we would all recognise that it's a pretty sad position for trusts to have to be in to be organising food banks for their employees. But that's kind of where we are at the moment. So I would say, again, if you're part of the union, you might be part of your staff side group. These are the people who can have contact with those who are high up in the trust and actually ask those questions. This is something that I've been doing locally at my trust. Our staff side union, we are asking the trust what their plans are to support. They've been directing us to some of the things that are being organised by our local integrated care board. And they're talking about how lots of the staff that work at the hospital, also residents in the area, so they'll be able to access support that way. I think this is an area in which we can challenge our employers, because we as staff are the greatest assets of any organisation. And if people don't have enough to eat, they aren't able to heat their homes, they aren't able to spend money on getting to work, there would be no services. So they have a duty of care to us as well as their patients. I think we also find that lots of trusts will have employee benefit schemes. So there might be something in there that would be useful for you, things like childcare vouchers, transport support or bike schemes, discounts at certain shops, and those can be really useful when you're planning for something like a Christmas presents. I think the next one around getting money literate, I think this is something I've not always been particularly money literate, and I think there's lots of people who might be eligible for certain benefits but not realise. It's not just for people who aren't working, and this may particularly apply to those on the lower banding. So your maternity support workers or your healthcare assistants, your domestic teams, people who are working part-time. So it's worth using some of the resources that I'm going to talk about a bit later to see whether any of those are applicable to you. Something like working tax credits, child tax credits, tax allowances for if you're married. There's all sorts of things, and they don't necessarily automatically get applied to your tax. It's always worth checking, whether you're on the right tax band as well. If you've had a change of role or you've changed your hours, or there's lots of reasons that things can be adjusted and be slightly wrong. So it's always worth looking at that. Most of us would have heard of Martin Lewis's Money Saving Expert website, really useful, and you can sign up to email updates with things like good offers, advice, and links to other organisations that might be able to support. I would say also it's really, really worthwhile seeking some financial advice before pausing or quitting a pension scheme. There can be implications from that, that it's not necessarily very easy to understand. So actually seeking some support around that and some advice before doing that is a really good idea. You may still go ahead and want to do that in the end once you've thought about it and heard, so that you're making an informed choice, but it's definitely worth checking. I think the next one is around being mindful of the impact that money stress can have. And similarly, I think there's been so much in the press throughout the last few weeks, the summer, talking about this impending crisis and how awful it's going to be. And, I know I've been feeling anxious because of that. And I think there's tools out there to try and understand what impact it's going to have on you in your particular situation. But also just that anticipation of what might be going to happen or what is happening, that causes a lot of stress and anxiety. We're in a situation now where we've all been living in a lot of uncertainty for the last 2.5, almost 3 years now with the pandemic. We've had a summer where we've got a changing Prime Minister. There's so much uncertainty, so much doubt about what the future is going to look like. And a lot of us have used up a lot of our stores of resilience. We're seeing lots more people accessing for the first time mental health support. I think there's probably a lot more people out there who could do with accessing some of that. And that's why I've put this in here. If you think about the capacity you have to give care to your clients, most of us as midwives, anyone involved in the maternity world, you've come into this because you want to be able to give help and support and be there for people. And I think lots of us come into this profession as people who want to help fix problems. And I think there's real power in knowing where the limits are of what we can solve. We can't always solve everything. We can only do what we can with the information that we have and the information that the people that we're working with give us. Knowing that, and knowing the impact that if you're up to here with what you can cope with, and there's lots and lots going on at home, that's going to be taking up a lot of brain space that you normally would have in order to give to your clients and your families and your mums and babies. So actually, if you've been reticent about accessing support in the past, or it's just not something that you're used to doing, or you don't know anyone who's done that before, I think sometimes seeing it as something that is beneficial, not just for you, but for your family, for your friends, for your children, and for your clients, to make sure that you've got the capacity to give what you want to give to them, is a way of kind of getting around that kind of fear factor around accessing support. One of the upsides of the last few years that we've been through is that there's a lot more focus and a lot more availability on support for staff through our NHS organisations, or the NHS as a whole, or even in society as a whole. So most places will be able to help you access improving access to psychological therapies, IAPT, CBT, things like that really quickly. Other employee assistance schemes. Anything from, one-to-one support, group sessions, online if you feel a little bit like you'd like to talk to somebody anonymously. And there's actually a really good NHS leadership. I'm gonna send some links so that you can access these things I'm talking about, but a self-assessment for an online self-assessment for anxiety, depression and post-traumatic stress disorder, which tells you whether you need to go and seek extra help, and how you do that, or whether it seems like things are okay and at a manageable level for you. And the good thing about all of those things is they're free, so they're not going to add an extra impact that if you were seeking private therapy that would have. And then the last one is that I'm going to be talking to people today who actually are going to be less affected by the cost of living crisis, who might be insulated because of their income, or whatever else is going on for them. And if that's you, then what is it that you can give back to your community, your colleagues, the families that you work with and for? So it could be anything from increasing your charitable donations, reviewing your charitable donations and looking for local charities, or charities like the Trussell Trust, food banks, or whatever that looks like for you. It could be actually giving to a food bank locally, or it could be volunteering your time if money isn't something that you can give but you still want to give something back. So there are lots of opportunities to be able to give something back if you're in a position where you aren't worrying about this in the same way other people might be. And now this slide is about thinking about for clients and their families. And I think the first one I put in here because actually I think this is a difficult conversation to have with people. We're used to having lots of quite intimate conversations and asking intimate questions of people. This isn't necessarily one of those unless you are working in a particular role where this comes up. So working with vulnerable clients, say, or homeless clients, or refugees, asylum seekers. And I think if you are unused to asking questions like this, then actually planning how you might ask that question might be a really good way. Sorry, I've accidentally gone forwards. Of kind of getting used to asking that question and not feeling strange about doing it. So this is true for all sorts of difficult conversations, whether that's approaching, the fact that you need to make a social care referral, or with a colleague, you've got somebody that you'd like to discuss something that you've overheard them saying, or, whatever that is. Planning how you might broach that conversation can be really, really helpful if you aren't used to doing that, or if you're feeling anxious or nervous. So I've put an example here. Lots of families are struggling with the cost of living crisis. How are you managing? And actually, I think that what that does is put it into context. So actually, you're not alone. If you're suffering and struggling, then actually that's a very common experience. It's not something to feel embarrassed about. It's not singling them out to say that you think they will be because of whatever judgment you might have made. So it's kind of opening up that question. They might say they're fine, it's okay. Or they might say, actually, no, it's not fine. I'm really struggling. I'm really worried about the future, or I haven't been able to pay my fuel bill, or whatever it is that they're struggling with. And then obviously the next part of any opening up a conversation about any difficult topic is worrying about how you might respond. And I was talking about how lots of us in the midwifery world, the maternity world, all the helping professions, we can be kind of fixers. We want to fix the problem. But I think something that's really, really important to remember is actually that listening in itself is therapeutic. And giving somebody a space to talk is therapeutic in and of itself. Acknowledgement. So an example of what you might say back to that question would be, that sounds really stressful, that sounds really hard. And then have you considered X? I could make a referral to a local service that does X for you if you like. So what you're doing is you're saying, I hear what you're saying and I'm listening to you, and I'm acknowledging what you're going through before you start going into fixer mode, which is also super valuable thing to be doing. But there's a quote by a really amazing psychologist called Karen Treisman, says, every interaction is an intervention, and you don't have to be a therapist to be therapeutic. And I think this is a really good example of that. Just giving somebody a space to check in with them, to let them know that you care about how they're doing, and you care about their circumstances, and that you're hearing them and giving them a space to talk about how they're feeling about it is, I think, a really, really important thing. The next one is around knowing your local context. So this is about getting to know your local area, your region, and even things that are available nationally. And on the next slide, I've put some examples of my kind of local toolkit, and then you can go away and adapt that and add in any local organisations, regional organisations where you work and where you live. But there are so many, and this is it's an amazing thing to recognise how many people have set up organisations and charities that actually put in amazing practical financial resource support for families. Some of these are really small grassroots ones, and this will be your local, and some of it's more national, and it might be advice and signposting, things like that as well. So knowing what's available in your local area and what would work for which circumstances is a really, really important thing, because being able to make referrals to people that are going to give people the support that they need in a meaningful way is a really big gift that you can give to your families. It is worth thinking about as well that another way of accessing support if all other avenues have been exhausted is around children's services, so social services. And this would be looking at a child in need or a Section 17 assessment. And this is looking at, it can be practical financial support for a child in need, and a child who's going to be living in extreme poverty, who's not going to be able to have a warm home, food on the table, to have a home at all, so children at risk of homelessness, and that includes people who are sofa surfing, staying with friends or family. Then that can be a way of getting them that support that they need. And another significant group it's very difficult to get support for are those who have an RPF condition, so that's no recourse to public funds, means that they can't have any benefits, they're not eligible for benefits because of immigration status. And that's a real challenge as a midwife when you're working with somebody. And sometimes we might find that support isn't available until a baby is physically born, and that can be really, really challenging too. But actually that Section 17 of the Children's Act is there to step in when there are no other options. And I think really important to reassure families that this is about supporting them. It is absolutely not about removing their children. It's not because you're worried that their children aren't safe in their care. It's about the support that they need to stay together, and to live out of poverty or abject poverty. The last one I put is about assessing the capacity of the client. And I don't mean doing a mental capacity assessment, even though that is always something that's worth having in the back of your mind. But this is more about, what's going on for that person, and do they have the capacity to go out and follow up information that I've given them? Do they have the capacity in terms of, do they have internet at home? I've put here considering somebody who has older children, so they've already got children they're caring for, who's socially isolated, with extremely limited money, might not be able to get to the job centre or get to somewhere to access support. She might be struggling with getting children to and from school. She might not have anyone to look after the children if she wants to go to an appointment for something. Or a young mother struggling with mental health problems might not have that kind of emotional capacity to do what she needs to do. Especially, somebody suffering from depression, we know that can really limit their ability to go out and be proactive about, getting their needs met. Or somebody with complex substance use, their addiction is going to be causing them to prioritise using and finding the whatever it is that they're taking, and they're not going to have the capacity to be able to meet their other needs necessarily. So those people will need more support from you to access the support that is available. So, somebody who's really well supported, having their first baby, all those others that kind of just as normal, as kind of uncomplicated as can be. If they're a bit anxious about something, you can give them IAPT contact details, and you can probably be confident that they're going to be able to access that on their own. But for somebody else, like what some of the people that we've talked about just now, it might be making a referral for them on their behalf rather than getting them to do a self-referral. It might be helping chase that up and speaking to the people that you've referred to. It might be advocating for them if they've missed an appointment not to discharge from a service. It might be trying to find them a family support worker or a key worker who can help them get to appointments, who can encourage them by going to meet them at home and bringing them. So it's about making that judgment about what, how much input is needed from you and how much have they got to give in order to support them in the best way possible. And then this last slide is just an example of my directory. These would be things that I would use on a regular basis. So at the national level, you've got things like the Citizens Advice Bureau. You've got Gingerbread, which is a charity that supports single parents. Crisis, I'm sure lots of us are referred to, is around support with housing. It's not necessarily going to get people housed, but if they have issues around the quality of their housing, or they've been made intentionally homeless and they want to appeal that, then Crisis could support them. The Trestle Trust I've mentioned is a food bank charity, but there are lots of local organisations as well. I've put Twitter on here because actually I find Twitter professionally a really, really useful space. So there are lots of organisation and people on there that will share resources, share links, and I think, for me, it's a really, really useful space for finding out about things that I wouldn't know about otherwise. The Maternity Action are a really amazing charity that give free legal advice on various aspects of kind of maternal rights. So that might be anything from access to NHS care for women who aren't eligible for free care, or access to information and support around people who have been maybe made redundant or having work issues in pregnancy, to benefits and welfare and things that you might be able to access. Again, Turn to Us, I think was originally kind of created for families in Edinburgh, but actually it has loads and loads of resources in terms of, there are lots of charitable grants that you can apply for support in the short term, or on a slightly larger scale as individuals, and support for your families to access that too. It's a bit of a repository for that, because it can be quite hard to really drill down and be aware of everything that's available in your local area. They also have helplines and kind of advice. And the Fuel Bank Foundation, you can probably tell from the name, will give small grants to people in need with support for their fuel needs. On a regional level, for me, I'm based in London, so this would be a London-wide kind of thing. And there is an amazing charity called Birth Companions that I work with quite a lot, who will help people. They'll have one-to-one support for women in that kind of in need of more social support and help to access services. Little Village is one of lots of charities that redistribute used baby children items, so anything from clothes to toys to prams and car seats. There's a really amazing number of organisations that will take nearly new items, pre-loved items, and distribute them to people who need them. And this actually is another thing that at where I work, we have a maternity unit Instagram account, and we'll often have people getting in touch with us through that account saying, I've got some premature baby clothes that I'd like to donate, can you take them? We can't take them. I mean, we have done in the past, but we've run out of room. So what we do now is we direct people to things like Little Village. And in the local section here, I've got the E5 Baby Bank, which is one local to me, but there's lots of these. And it's really worthwhile sharing this with your families in terms of people who need it, and also for those people who have things that they can give as well. And that's another way that we can kind of help people do what they can do as well. Back to that regional level, there is a really amazing resource from Project 17, which is going back to that Section 17 of the Children's Act, and it has a booklet that gives advice on how to access support, how to deal with issues that families have commonly had when accessing support, because sometimes it can be a bit tricky to navigate those systems, and other organisations that people might need in terms of appealing decisions, like how to find a community lawyer that you can access for free, things like that. I've put on here the ICS, and I previously mentioned that. Most integrated care systems, and I'm going to just explain briefly my understanding of what they are, because they're very new and it's a change. So these bring together health and care and local authorities and charitable organisations in a region that has been prescribed by the powers that be, to work together for their local population. So for me, it's North East London. And they have a responsibility and a remit to look at health inequalities, and most of them will be making plans and looking at what they can do as a system to support families during this time. I've also put the local maternity and neonatal systems, which is the maternity bit of the ICS. So in mine, my hospital works with all the other maternity units in our area, and between all of us professionals from those areas, we'll be able to signpost and put together information, bringing together information for families about everything that is available in our area that can support them. And all LMNSs will be in the midst of making their equity and equality plans, which should be taking into account social deprivation and what the way people are living in their area, and what maternity services and others and partners can do to help families locally. Then just a little bit more about that local bit. The local authority, so your local council, is a really, really important player on this. It's worth signing up for updates, email updates for your own council, and also for the council if you work in a different council, because lots of them will have individual schemes, and again be sharing lots of collated information about what's available in the local area, very small organisations you might not be aware of, extra support that they're putting in place. So it's worth getting those on the go as well. And just checking with colleagues. Midwives who care for vulnerable women are particularly knowledgeable about this stuff already because they are regularly referring families and assessing what signposting needs to be done. So make use of the resources that are available to you and build yourself a directory so that when these conversations come up, which they are going to increasingly over the next few months, you've got something to do and something to go to, so you feel like you can make a difference and you can fulfill that need to help fix that we all have. Thank you very much.
Okay, I think that was great, and I wish Tamsin was here, but I think we will definitely, as I said earlier, have her back so she's live, so we can quiz her on all of these. But I have to say that the biggest useful thing I think is building your own directory. I know this is something you can learn as a student, certainly, but I think we can all learn because you gather up information from your practice, and it's very useful to be able to share. But also at this time, information is really so important for ourselves and for the women and families that we're looking after, because if we don't know, what is it now? Is it the AA? You know a man who can, or you know a woman who can. And of course, what Tamsin was saying about her, the local, your other local midwives who've got enormous amount of information to be shared, do get in contact so you can build up your own directory and be able to care for your women, but also care for yourself. And I would also endorse the money saving expert, because that's a really good site, and you get a fantastic little newsletter coming through electronically, which gives you lots of tips and also some little vouchers and things that you can be aware of, which is always useful. So thank you to Tamsin for that. And if you have questions for Tamsin, you'll need to put them in the chat box and we will forward them to her. It's a little welcome home email. But now I'm delighted I have Dr. Denise Tehran with us this evening, and I know that many of you will know Denise. She's an education director of Expectancy. She's a midwife with over 35 years of experience, an international authority on maternity complementary medicine. I don't think I know anyone who has her level of expertise in this. She's authored many chapters, articles and books on complementary therapies. She's spoken all over the world on the same. And the reason why she set up Expectancy, which is a fantastic resource, was in response to the growing interest amongst mums and midwives for using complementary therapies in pregnancy and birth. She really wanted to address and make sure that was safe for both mothers and midwives. I think she'll be talking about that now. She's taught all over the world, as I said, and she was described to me yesterday as a powerhouse, and I think she is, and I'm looking forward to her sharing aromatherapy and midwifery in accident waiting to happen. Welcome, Denise. The screen is now yours.
Thank you, Sue, and thank you so much for asking me to join you this evening. I was fascinated by Tamsin's talk, actually, and I think the thing that came through to me was the need to look after ourselves, and it is a very difficult time for all sorts of reasons. But when we look at the Nursing and Midwifery Code, there is actually a clause in there which states that we have a duty to ensure that we look after ourselves and the safety of others in our care. And, that I think is partly what Tamsin was saying there, but it's also very dear to my heart when we look at things like aromatherapy. As some of you will know, I've been using complementary therapies for a very long time, and I'm qualified in a range of therapies. I do more teaching on aromatherapy than most other therapies, although my personal preferred therapy is a form of reflexology called reflex zone therapy. and I am trained in a range of others. But when we look at complementary medicine or complementary therapies, I think it's very easy to think that it's one thing. It isn't. It's actually a whole range of many, many, many different complementary therapies, each of which has its own mechanism of action, indications, contraindications, and so on, and evidence base, of course. And aromatherapy is by far the most popular therapy at the moment amongst expectant and birthing parents, and increasingly amongst midwives. I do think there is an absolute joy in being able to use aromatherapy. It certainly has a lot of advantages for the people for whom we care. I'm not convinced that we ought to be calling it aromatherapy because, of course, most midwives are not fully qualified aromatherapists. And even if you are, sometimes it can be difficult to apply the principles of aromatherapy to the way in which you use it within your standard midwifery care. We are still midwives and we're still registrants whichever country we work in. But there is definitely a place for bringing in essential oils and massage, i.e. aromatherapy. Now, the reason, I'm just going to screen share, but the reason I think that we decided that it would be useful for me to chat today is because of midwifery aromatherapy in the press. And sadly, only fairly recently, we have had two major newspapers in the UK, first the Times and then the Daily Mail, describing our use of aromatherapy in midwifery as a quack therapy. If you want to see the response that I sent to the Daily Mail, if you go to the Expectancy website, you will find it on my blog, because whilst the Times was relatively generous in the way that they discussed it, the Daily Mail most certainly was not. It was an article that was full of errors, factual errors, full of biased attitudes, and really quite shocking. However, I have to say that whilst I cannot comment on the Nottingham University's situation because it is under review with the Ockenden team moving from Telford to Nottingham, I do have to say that I have some grave concerns about midwives' use of aromatherapy in general. And in no way am I casting aspersions about any particular units. But I think what happens with midwives is that we're so excited and enthusiastic about bringing in something that is wonderful for the parents for whom we care, that it's quite easy to deviate from the parameters that we're allowed to work within, and then to sort of think, oh, well, we'll just do that, or we'll just do that, or we'll just do that. Now, for those of you who may be less familiar with aromatherapy, it involves the use of plant essential oils. They are oils extracted from plants, and each oil contains up to 300 chemicals which have physiological effects. And those may be very positive, or they may be not so positive. And many essential oils are very relaxing, whilst others are stimulating. Some will raise the blood pressure, which we would not want. Others will reduce the blood pressure. Many of them are pain relieving. They actually contain chemicals which have been shown to be analgesic. And all these chemicals have lots of different ways of impacting on the physical body, but also on the emotional side of the care that we're providing. So when you either inhale an oil or you have that oil in contact with the skin, whichever way they are administered, the essential oil chemicals are absorbed into the body. They go around the entire systemic circulation, including crossing to the placenta. And when you inhale them as well, they not only go down into the lungs and the circulation, but they will pass via the olfactory system up to the limbic system in the brain, where they will impact on mood and memory and various other psychological and emotional issues. So I think it's important that we understand what's actually happening with aromatherapy. There is definitely a place for it. Please, I'm not saying anything negative today. I am actually trying to discuss aromatherapy in a way that will help you to take forward your practice if you're already using aromatherapy, maybe to consider using aromatherapy with the appropriate training if you are not yet using it, and also to be able to advise parents on the safe use of aromatherapy. I think one of the problems for us is that because aromatherapy involves lovely massage, which can be very relaxing, and nice fragrances, people think that that's all it is, but in actual fact, it's not. The chemicals act in exactly the same way as medicines, as drugs. They are absorbed, metabolized, and excreted in exactly the same way as drugs. They're all metabolized via the liver, and they're excreted either in the breath or via the skin in the sweat, or via the urine, and to a lesser extent via the bowels. But when we use aromatherapy or essential oils in midwifery, it's really important that it's not just something that is done for everybody. You cannot have essential oils available in a standard dose and a standard blend of different aromas for everybody. It's got to be individualized. So really, what we're saying is aromatherapy needs to be viewed as a clinical intervention. Yes, we want to enhance the birth environment. We want to help parents relax and prepare for birth or recover from the labor, but we have to use it within the parameters that are part of our midwifery practice. Even if you're a fully qualified aromatherapist, when you're using essential oils and massage as a midwife in your midwifery practice, you're using it as a midwife. And therefore, we have to use the oils and the techniques for administration within the parameters in the UK of our Nursing and Midwifery Council registration, or if you're in another country, within the parameters set by your national regulatory body. We also have to take into account regulations from our employers. We have to have indemnity insurance. We know that for our practice anyway. With aromatherapy, as opposed to other complementary therapies, we have to look at the principles of medicines law. Interestingly, you can't, they're not able to be put onto the prescription sheets because they're not substances which are in the British National Formulary as a medicine, apart that is from peppermint oil. But everything else is not officially a medicine. They've not been tested in the same way as drugs. However, we have to adhere to the basic principles of medicines regulations, which state you use the right substance at the right time for the right person in the right dose, the right frequency, the right method of administration, the sort of rules and regulations we apply to drugs. In addition to that, we have health and safety at work and the control of substances hazardous to health regulations, which basically mean that we are required both as employees and employers or managers, we're required to ensure that whatever is done is safe, not only for the patients or the people in our care, but for the people working with those substances. And that doesn't only mean ourselves, it means everybody else who's exposed to aromatherapy oils, including portering staff, domestic staff, everybody who comes through the area in which we are working and using aromatherapy. And then since 2020, there's been a slight change in what organisations regulate aromatherapy. Now, prior to Brexit, the European Union had various directives related to herbal medicine, which includes aromatherapy. But since Brexit, most aromatherapy practice, as opposed to the production of oils, for example, but the actual clinical practice is regulated largely by the cosmetics regulations. The reason it's under the cosmetics regulations is because they're not drugs, and therefore they've got to sit somewhere, but it can be a little bit difficult because they're not cosmetics either. So people are sort of not quite sure what exactly regulates aromatherapy. Now, when it comes to our use of aromatherapy or essential oils within our midwifery practice, because it's something new, and for some people it's something a bit odd, it's one of these alternative therapies that can be readily dismissed, and there is less evidence overtly available. I'm not saying there's no evidence, but it's less readily available. We have to justify our use of complementary therapies, including aromatherapy, twice over, really. And there is still a lot of skepticism about using these so-called alternatives. I don't use that term, actually. I think that anything that we use that is outside mainstream healthcare in pregnancy, birth, and postnatal has to be complementary to standard maternity care, whether that is provided by midwives or doctors or doulas or anybody else. However, I would say there is a need to be ultra cautious. And therefore, as a general rule, I would say that aromatherapy should really only be offered for pregnant, birthing, or postnatal parents who have no diagnosed complications. And that means that they will be outpatients, not admitted to the antenatal ward with a complication. They can be used within a low-risk midwife-led birthing centre, but generally should not be used on the main delivery suite, where there are, by definition, people with complications, as with antenatal inpatients. Now, that's not to say that you can't use aromatherapy for everybody on the delivery suite, because, of course, occasionally you'll have women who have gone to delivery suite because they're not eligible to go to the birthing centre, but whose pregnancies have gone through, they've progressed normally, and the birth is actually progressing relatively normally. It's those people with complications, any deviations from normality. Similarly, even in a midwife-led birthing centre, it's really important to discontinue essential oil use at the beginning of the second stage, or preferably, if you know when it is, at the start of the transition stage. And the reason for that is that essential oils should never, ever be used on or near neonates, newborn babies, up to about the age of 3 months, I would say, actually. And there are several really important physiological reasons for this. One is that the baby's skin is very sensitive, therefore you would not want to be putting these chemicals on the skin. The second is that babies in part recognize their own mothers through the sense of smell, and the oil vapors and the aromas may mask that. The other three reasons are really important. One is that the baby's liver is immature. We know that. It's busy metabolizing fetal hemoglobin, and it's not able to cope with additional metabolic requirements for the excretion of the waste products from essential oils. Similarly, the blood-brain barrier is underdeveloped, and a baby that inhales essential oil vapors, the aromas, some of the chemicals can be toxic, and because they pass rapidly across the baby's blood-brain barrier, that can cause an increased risk of cerebral irritation. With the liver issue, there is an increased risk of jaundice, becoming kernicterus, and that sort of thing. And then the last issue is to do with the baby's immune system. All essential oils are antibacterial to a greater or lesser extent. Some are antiviral, some are antifungal, kills all known germs sort of thing. But the baby's immune system is immature. Now, if you expose a newborn baby whose immunoglobulins have not fully developed, so under sort of 6 to 8 weeks, if you expose them to the anti-infective properties of essential oils, you may impair the maturation of the baby's immune system, which potentially risks that baby growing into an adult who is less capable of fighting infection. So one small amount of essential oils at birth is not going to cause a problem, but we do need to be absolutely careful at every stage that the oils are not used on babies, and where possible they're not used near babies, which is why I'm saying it's better to discontinue the use of essential oils by the second stage of labour, so the baby's not born into an atmosphere with essential oil vapours. Similarly, you don't put them into a birthing pool. You would not want that baby's skin to come into contact with water that has had the essential oils in. This message I want to get across to you more than anything else. And if you can smell the aromas, if you can smell the smells, the fragrances, however pleasant they are, when you smell them, you are inhaling chemicals. Every single person in the room where essential oils aromatherapy is being used is exposed to the chemicals within the oils. They will then pass through to our systemic circulation. What that means is that when you are using aromatherapy, by whatever method, even if you're just massaging it onto a birthing woman's skin or whatever, the chemicals in the air affect all people in the room. That's the parents, the babies, and all staff exposed to the aromas. And it is possible that some essential oils can be contraindicated for staff with particular medical conditions. If they're on any medication, there is always a risk of drug-oil interactions. If they have active epilepsy for which they require medication, then they should in no way be exposed to these essential oils. If they've got high blood pressure and they're taking antihypertensives, they don't want to be exposed either to oils which increase the blood pressure, which we tend not to use in midwifery, but neither do they want to be exposed to oils that reduce the blood pressure, because it can potentiate the action of the antihypertensives. And most importantly, particularly when oils are being used in the birth centre, midwives who are pregnant or trying to get pregnant, or going through infertility treatment or anything like that should not be exposed to the chemicals from oils which are designed to aid labour progress. And I have had quite a few midwives who have contacted me and said, look, I'm working in the birthing centre and we have essential oils, but actually I'm in early pregnancy. I don't really want to tell anybody. I did once have a poor midwife who was in tears on the phone, who said that her manager had refused to move her from the birthing centre, even though the midwife had admitted that she was in the first trimester of pregnancy. And I think this was because the manager didn't understand the impact of the oils and the chemicals. We need to think of aromatherapy vapours in exactly the same way as when we are exposed to chemicals from cigarettes or other things. It's like passive smoking. Yes, you might be able to see the smoke of a cigarette, and no, you can't see the vapors of the oils. But if you are inhaling them, you are inhaling chemicals. And this means that it is absolutely, completely contraindicated for diffusers or vaporizers to be used in a birth center or a maternity unit. It is something that is often used to fragrance the atmosphere. And it can be very pleasant, but it is just not safe within the birthing environment. If you visit a woman at home, a family at home, and they've got, one on in the home, that's their prerogative. However, my advice would be that you suggest to them that they only leave it on for 15 minutes and then turn it off for the rest of the hour. You can't stop them using the vaporizers at home. But I think when it is on our premises in the NHS or other maternity unit, it's really unsafe. It's quite unethical, actually, to be using diffusers, which the vapors and the chemicals from the oils may adversely affect people in ways that you cannot anticipate. I'm actually allergic to geranium oil and increasingly to rose oil, because geranium and rose share some of the same chemicals. And if you think about somebody, you might know somebody who's got a sort of shellfish allergy or something like that. And so when they first start developing this allergy, they may get, just a little bit of nausea. And then next time they get a bit of sickness. And then next time they get a bit of diarrhea and sickness. And eventually, if they don't recognize it and they continue to be exposed to the allergens from the shellfish, they can have an anaphylactic shock. And that can be fatal, And the same thing applies to the chemicals in the essential oils. Now, I'm not trying to worry you, but I am trying to make you understand that actually the way that we are currently using essential oils in many maternity units is actually not only contravening health and safety at work and control of substances hazardous to health, it's actually really unethical, because people might not like the aromas, they might be allergic to them, or they may be seriously, affected by one or more chemicals. And it's a difficult situation, because I think midwives get very excited about the essential oils and using them and making the room smell nice and providing a nice birthing environment. But actually, you do have to be extra, extra cautious. I just want to finish on Clary Sage. Now, Clary Sage is probably the most well-known oil apart from lavender. It is definitely one that is very, very popular amongst expectant parents. It's also one that's frequently used when midwives have set up aromatherapy services in the birthing centre. And it can be a very, very nice oil. It's a bit medicinal in the smell, but if you blend it with other oils, it's okay. And it can be really effective. Clary Sage reduces the blood pressure, and it has some antidepressant effects, and it's got some pain-relieving chemicals in it. But it is definitely an oil which should never be used in pregnancy until term. So you would never use Clary Sage until 37 weeks of pregnancy minimum. And neither should you use it when labour is well established. And when I'm teaching my courses, I always say to the midwives, think of Clary Sage as nature's syntocinon, not oxytocin, not natural oxytocin, but nature's syntocinon or pitocin. If you are thinking that it's nearly time to get somebody to set up some syntocinon because things have deviated from normal, then maybe that is a place to use Clary Sage oil prior to see if it works. But if labour is well established, no way would you want to put up syntocinon, because the woman's body is doing its own job and it's working efficiently. If you use Clary Sage in well-established labour or when it's inappropriate, initially you can find that the woman will develop hypertonic uterine action, so the contractions will get stronger and longer and possibly more frequent. And that in itself may lead to fetal distress. And that's a very common picture that we are seeing around some of the units. However, what is also happening is something called hyperpolarization. Now, hyperpolarization means that whenever you have a drug, you need a period of time before that drug kicks in and starts to work and be effective to do the job that you've prescribed it for. So here we have sorry, Sue, can you see my cursor along the line? Yeah, okay. Here we have the point of administration of a drug. And gradually, as the amount of drug in the bloodstream increases, it starts to work. It starts to do its job. But if you use a drug inappropriately, over too much, too often, too high a dose, or whatever, eventually it gets to the stage where it increases its activity. And that's what happens with Clary Sage. So here is the normal use of Clary Sage. Here is some prolonged use of Clary Sage, and this is where we get the excessively strong, excessively frequent contractions of the uterus. Now, if you continue using it and you haven't recognized that Clary Sage is beginning to cause excessive contractions and fetal distress, what then happens is the bloodstream level goes over the edge and starts changing to the point where the effect of the drug or the oil diminishes until eventually, in the case of Clary Sage and contractions, the contractions peter out and the labour stops. And I can tell you the case of one woman who was in the birth centre. She'd brought in her own essential oils, including Clary Sage, and she was labouring well. She was using Clary Sage and she was being cared for by midwives who didn't use aromatherapy, and the midwife she was working with was, unaware of aromatherapy, really. And then it got to the stage where she started to have some excessively strong contractions, and the CTG monitor showed that there was the development of fetal distress. And nothing happened. It wasn't bad enough to transfer her over to delivery suite. So everything was fine. The woman continued using the Clary Sage, and then the contractions started to peter out. They slowed down, and eventually they tailed off. So she was transferred over to delivery suite, where there was no aromatherapy. And after about an hour, the contractions came back, and they came back with a vengeance, and she got back into what appeared to be well-established labour. And so they said, we don't need to keep you in delivery suite. We'll take you back to the birth centre. There's co-aligned, but it's still a transfer across the corridor. And she went back into the room that she'd had before and started to use her Clary Sage again. And this time, the hypertonic action element was very, very short, and then the contractions stopped. So they took her back to delivery suite. Poor family was being carted backwards and forwards. Eventually, she ended up with an emergency cesarean, and everything was fine. But the situation arose because the parents didn't understand about the overuse of this oil, and it happens with other oils too, but Clary Sage is the main culprit. And the midwives caring for her didn't understand it either. So my message to you this evening is we have to use aromatherapy as a clinical intervention. That means we have to know how it works, what is the correct way of using it, what to look out for in terms of side effects or complications. And, think about it for the individual. It isn't appropriate for everybody. So what can we do for this individual parent? And look at the essential oils as drugs. Remember that if you are inhaling the vapors, the smells, you are also exposed to those chemicals, and they may affect you as much as anybody else. And Clary Sage is notorious for increasing menstrual blood flow when midwives are menstruating. It causes menorrhagia. Yeah. I think my watchword is you need to know what you're doing. I am sorry to say that there are a few midwives around the country who love doing aromatherapy, and they love doing the massage and using the oils, but they've stretched their boundaries a little too much. And actually, we need to be cautious, particularly when this is something which is not necessarily a mainstream part of midwifery practice. So that's my message, Sue. Have we had any questions?
Well, Denise, I'm just amazed, and I always learn something when I listen to you, but this was really good, really helpful, especially the Clary Sage, which I didn't know about. I mean, I don't necessarily use aromatherapy, and know a little bit, but wouldn't presume to be using it in your way. And we've had a lot of comments. I think people are kind of stunned. So we've got Helen. Hi, Helen. She says, brilliant session on aromatherapy. Lots of interesting points made. Claire Dale, well, she said 3 things. Hello, Claire. She says, this session has been really eye-opening, especially its comparison to passive smoking. I was unaware of how serious the implications could be. And then difficult to use your aromatherapy to good effect without affecting others in the area, whether that would be staff or other women. I think that was a really important point. And when you said about the menorrhagia, well, I mean, that, gosh, that really brings it to life, doesn't it?
Yeah.
And then Claire also says, may I explain why I haven't seen its use yet when on placement. And then Juliet Samuel, hello, Juliet, you've had 2 goes too. Thought-provoking and adds another dimension, deeper knowledge base to which practice and explore further. The COSH implication is excellent. And then she says, although not classified as drugs, but capable of having variable effects to not only the user, might it be that in time there will be some form of either national professional control to practice?
Well, my response to that is, don't get me started.
Okay.
As you know, Sue, I've been fighting for a lot of this for many, many years. It really rather concerns me, given that something like 80% of pregnant women in some areas are using complementary therapies, and many of those are using aromatherapy. It concerns me that the NMC's latest standards for education have actually taken out all mention of anything to do with complementary therapies. The previous ones, can't remember the date, 2009 or something, did at least mention raspberry leaf tea in respect of over-the-counter medicines. But I really think we have gone past the point where we as midwives should be seeing aromatherapy and other complementary therapies as simply something that sits on the edge that midwives might learn about after they've qualified. I'm not expecting students necessarily to be able to practice aromatherapy at the point of qualification. But I absolutely believe that all students should be given an introduction to the issues, okay, we're talking about aromatherapy tonight, but then raspberry leaf tea. There are midwives who say to women at 39 weeks trying to avoid an induction, drink raspberry leaf tea. That's actually quite dangerous. It should be started at around 30 to 32 weeks and built up gradually. And there are other things. For example, women who want to avoid induction, who go for reflexology to a practitioner, and the practitioner says, can you check with your midwife if it's okay to have reflexology? So the mother says to the midwife, is it okay? And the midwife says, well, if it's lovely, how relaxing. Yes, if you like it, that's great. And she goes back to her therapist and says, the midwife says it's fine. Now, there's been no professional discussion between the midwife, who knows possibly nothing about reflexology, and the reflexologist, who may not have any maternity-related training. And yet, here we are, we're sort of making judgments about what is and isn't safe. And I truly believe that we need to strengthen what we are doing as midwives and doulas, actually, with complementary therapies. It isn't something to be played with. There is a deep theoretical background to each therapy. You can't just learn a bit of massage and blend up a few oils and chuck them around and, enjoy that. It's great, but it's not quite professional enough. And as for regulation, in a more formal way, it's actually quite difficult, because essential oils, like all herbal remedies, are not regulated in the same way as medicines. So medicines have undergone stringent testing at various stages, multi-million-pound testing, and then they are approved for various uses. But because herbal remedies are herbal, they're natural, they are available to everybody, there is no way that a company, a drug company or any other, would do all that testing and then patent something. Well, you can't patent something which is readily available in the hedgerows or whatever. And so it's never going to be regulated to the same level as medicines. And all the authorities can do is say, well, you cannot make any medicinal claims for herbal remedies, including oils, and you can use them as nutritional supplements if they're other types of herbs and that sort of thing. But it's really difficult. I personally would like to see greater regulation of aromatherapy and complementary therapies within midwifery. This is why I think it's an accident waiting to happen. And the problem is that huge enthusiasm for these alternatives means that people don't always recognize the depth of knowledge and the issues around safety that you need to consider. I wouldn't have been teaching aromatherapy and other therapies for nearly 40 years if I didn't think that they had a value and a benefit to expectant parents, to the organization. They can facilitate normality, they can reduce intervention, they can improve midwifery job satisfaction as well as parental satisfaction. But I wouldn't have been doing that all these years if I didn't think it had some benefit. However, whether or not we ever get to a stage of regulating it is a question for the future, probably. Actually, Prince Charles is or King Charles, I should say, is very, very pro complementary therapies. So maybe I'll have to have another go at him.
And what a perfect way of bringing to conclusion, because I'm very conscious, and audience, I know this has run over the hour, but it's been fantastic to have Denise's expertise, because I think this might be, I won't say starting the process, but it is very important to share this information and start thinking about it for those midwives and students who are watching tonight and over the next few days and weeks, to think about it as not just a nice sweet smelling something. It's not like the stuff that you plug in at home that just smells nice, yes. Though of course that might have effects also that we don't know.
Well, they do, and some of them are synthetic and they're even worse than the natural.
Oh my goodness. Oh no. That is, you can't take anything for granted. And I was going to, one of my questions would have been, or one of my comments is, I think there's a huge need for some research here. Yes. And I would have said, which one would you choose to research first? But I'm not going to open that debate because I'm very conscious of the time. So no, Denise. Yes, you can. Go on.
If anybody would like to read anything around some of the issues for aromatherapy and other therapies, if you go to my blog on the Expectancy website, there's quite a lot on there. You can read that.
And that, thank you so much for saying that, Denise, because it's reminded me. You see, I've had a little holiday and I've got out of sync and I haven't done the little list of resources. So we will have a list of resources on the page, on the Facebook page, which will point towards the Expectancy side. Fantastic resource for everybody. Very thought-provoking, as has been Denise's session, and Tamsin's also, but I know we need to put that all together. Now I'm going to say big thank you to our wonderful speakers. It's been fantastic, very stimulating. Now now that would probably be the rose aroma that would be very stimulating.
Or peppermint.
Or peppermint, I know that much. So I'll say a big thank you to Tamsin and Denise, and also to our editor and producer Amy, who's in the background there, Paul Rushworth and Deborah Murray, who are also feeding questions and comments through to me on my other screen. I just want to say next week's Maternity Hour is Going for Gold, UNICEF baby-friendly initiative in the university. And we've got the lovely Francesca Entwistle and Alison Taylor, who will be joining me. And don't forget to book for the Scottish Festival, 29th of November. It's in Edinburgh. That's a very good place to go around Christmas. There's a lovely Christmas market. I shall say no more. But in the meantime, thank you again to our speakers and to everyone who's supporting this, and our lovely audience. Well done for keeping going in the comments. Stay safe and take care, and we'll see you next week.